Hello, everyone, and welcome to our GN Fellowship webinar. Um, Today, we are celebrating finishing two modules, and we started the third module last month, and we just finished the first mini module of module 3. Today, we have very interesting webinar and very well distinguished speakers. We have our great moderator and board member of the GN Fellowship, Professor Mushtaba Qadri. He is board certified in internal medicine and nephrology. And we have our guest speaker, Dr. Omar Farouk from Penn State University. We have our case presenters and literature review, John Philip from Tanzania, Muhammad Al-Hadidi from Egypt. Dr. Shuru Al-Naggar is our moderator, and she is going to introduce the case presenters. She is from Mansoura University, Egypt. And we have Dr. Asma El-Imshati, who is going also to present a case today. So welcome Professor Omar Farouk from Penn State University, his GN expert, and I'm very sure that he will have very thoughtful and informative discussion for the TMA and its role, the role of plasma exchange in TMA and HUS. And as you can see the agenda here, we have another case presentation with post-transplant GN that will be presented by Dr. Muhammad Al-Hadidi. And John Philip is going to do a literature review on post-transplant GN. Then we'll have a discussion with Dr. Mushtaba Qadri, and also he is going to give closing remarks for this meeting. So again, congrats for all of our fellows. And as you can see here, all of our fellows finished Module 1, and Module 1 included the approach to glomerular disease, nephrotic versus nephritic syndrome, and first histopathology week. Then we focused on podocytopathy with the mechanism of glomerular injuries and the minimally change disease, FSGS. Then we start focusing on common glomerulopathies, membranous nephropathy, diabetic kidney disease, IgA nephropathy, and everyone finished the semifinal exams. And we have two groups of fellows. The smaller group are doing their module 2. So we finish the first mini module of module 2. We started with the histopathology 2, lupus nephritis, and last week they finished the small vessel vasculitis. Then they are going to start with the infectious related GN in pregnancy and onconephrology. Then they are going to finish this module with amyloidosis, February GN, immunotactoid GN, MPGN, and C3 glomerulopathy and cryoglobulinemia. And the major number of fellows are finishing their fellowship in 2 months. So they already finished the first mini module of module 3. So we just finished hereditary nephritis, post-transplant GN that was presented by Professor Mushtaba, and TMA. Then today is our case presentation and discussion. So only 4 weeks left for the scientific materials. We are going to wrap up, focus on traditional and novel therapies in GN management, start with lesson from treating GN patients, immunosuppression, the standard immunosuppression in GN, role of plasma exchange, and the last week will be focusing on novel and pipeline therapeutics. Then the next webinar will be the last webinar. Then there will be the final exam, the exit exam of the fellowship. The next webinar will be August 28th. So please mark your agenda. It's very important webinar. We have two eminent speakers. The first speaker is Dr. Pierre Ronco. He is a professor of nephrology in Paris, and also he is the editor of Kidney International Journal. And we have Professor Georgina. She is the editor of the J Nephrology, the Italian Society of Nephrology Journal, two eminent speakers, and this will be a very special webinar on August 28th, so please try to attend. Then graduation, please also mark your agenda. The graduation for the majority of the fellows will be on October 7th, 2024. So congrats for those who stayed with us, worked very hard. Now we are on the 9th month. So we are still having only less than 2 months to finish this long route. I'm going to stop by here. And now we are going to have our first case presentation. And I will let Dr. Shuru to introduce the first speaker.
Thank you, Dr. Amr. Our first case is an interesting case of thrombotic microangiopathy that will be presented by Dr. Asma El-Imshati. She is Assistant Lecturer of Nephrology in Mansoura University. Please go ahead, Dr. Asma. Dr. Asma, you are muted. Please unmute yourself.
Thank you, Dr. Shuru, for introducing. It is my pleasure to present my first case of thrombotic microangiopathy, first or not. Are you see my screen?
Yes, it is clear.
A 21-year-old female housewife married 1 year ago with one offspring delivered just before admission. One day before admission, she had severe bleeding during delivery of her first baby by cesarean section. The patient was in shocked state. Transfusion of 6 units of packed RBCs were done. However, the patient became oliguric, admitted in ICU and received IV fluid and 2 units of packed RBCs. During examination, patient was fully conscious, blood pressure was normal, pulse is 92 per minute, random blood sugar was accepted, neck veins were flat, lower limb showing no edema and no other abnormality except for urine output. She was oliguric. Urine output is less than 400 milli per 24 hour. Heavy lab showing increasing serum creatinine up to 2.5 milligram per deciliter, CBC showing normocytic normochromic anemia and the thrombocytopenia. The hemoglobin was 8 gram per deciliter and the platelet was 30,000. INR is increasing up to 2 and the ABTT is increasing to 39. LDH is increasing up to 983. ESR is increased. The direct comp test was negative. Liver function test showing increasing liver function, AST and ALT up to 108 and 105. Total bilirubin is increased 2 milligram and mainly indirect, indicating hemolysis. Indirect is 1.9. Major analysis showing protein plus RBCs 15 to 20 high power field. The white blood cells is 10 to 12. D-dimer was positive and the fibrin degradation product was high, 400 on reference 200. Blood film showing frequent chest suicide up to 5%. Pelvic abdominal ultrasound was done showing average both liver and spleen and average size and echogenicity of both kidneys. So the provisional diagnosis by the ICU staff is pre-renal acute kidney injury, DIC, due to massive blood transfusion. COMS test is negative hemolytic anemia, frequent chest suicide, thrombocytopenia, increased INR and ABTT, positive D-dimer, and increased FDP. Nephrological consultation indicating plasma infusion and the blood culture were taken and the patient started IV antibiotics. After 2 days, coagulation profile is normalized, but the patient remained oliguric and became overloaded and developed fits and disturbed conscious level. So we were confronted with this patient as she has a history of severe bleeding and hypovolemic shock necessitating massive blood transfusion, acute kidney injury, oliguria, overload, and rising serum creatinine up to 5 milligram per deciliter, disturbed conscious level, and generalized fits. Thrombotic microangiopathy becomes test was negative, hemolytic anemia, and thrombocytopenia. INR was increased under EBTT, but now normalized. Further investigation were done. Biology was negative, ANA is negative, C3 and C4 were normal. Renal biopsy was done. Adam TS13 was ordered, but the complement assay is not available at our unit. So we have two causes of acute kidney injury, ATN due to long-standing shock, or TMA due to massive DIC, blood transfusion DIC, massive transfusion DIC, and atypical HUS or TTV, massive transfusion DIC, and HELP syndrome or preeclampsia. Treatment priority. My first question is, would you support empirical early initiation of plasma exchange in persistent postpartum TMA with transient abnormalities in coagulation profile? The patient started hemodialysis alternating with plasma exchange therapy. So what is the exact cause of TMA, DIC versus TTP or HUS? We have different causes to determine the cause. The first timing of the disease, both occurring peripartum, DIC, TTP, and HELP syndrome may occur during the peripartum period. And the second clue was renal pathology. The patient underwent a renal biopsy showing focal edema and lymphocyte infiltration with some arterioles showing thrombosis and fibrinoid necrosis, and so the diagnosis is thrombotic microangiopathy with acute tubular injury. But unfortunately, it is hard to say that what causes the TMA based on renal pathology. So we have two another clues, Adam TS13 activity and the complement assay, which was not available at our unit at this time. So Adam TS13 was done, and it is 13%. So can TMA overlap occur? We have several case reports indicating overlap between DIC and TTP. This is the first case overlap between DIC and TTP, depending on the Adams T13 activity, which is 4%, and the coagulation profile. And there's another overlap in the case report, overlapping between DIC and atypical HUS, depending on the complement assay. And this is the last case, depending on the coagulation profile, persistent acute in the kidney injury, increase in the acute kidney injury, and the persistent TMA regarding the patient develop the daily plasma exchange, which improves the coagulation profile, but there is persistent acute kidney injury. And this is the last table showing the clinical features of pregnant and postpartum women, indicating consideration of the diagnosis of TTP and HUS, and intervention with plasma exchange, showing that normal coagulation profile or resolving DIC. So existing of the DIC doesn't distinguish between TTP and the HUS. And unfortunately, the patient received 10 sessions of plasma exchange with no improvement of the renal function. Currently, despite hematological improvement, this patient is still oliguric and dialysis dependent. And so this is my last question. Would you continue plasma exchange therapy in TMA cases with persistent acute kidney injury after hematological improvement of TMA or not? And thank you.
Thank you, Dr. Asma. Now we will have a take-home message by Dr. Mustafa and Dr. Omar Farouk.
Yeah, thank you, Dr. Asma, and thank you, Dr. Sharouk. I would like to introduce our guest expert for today, Professor Omar Farouk, who's out at Penn State University College of Medicine at Penn State Health. He works as an associate professor of medicine as well as the associate chief medical officer. And his residency was out at the University of Pittsburgh and fellowship at Milton Hershey Medical Center. He's a certified, board certified in medicine, nephrology, as well as hypertension, and also has a master's in public health and is pursuing an MBA. And he's also a GN expert. So I think I'm just going to wrap the introduction, and let's hear this exciting young faculty member who's a promising star on the horizon in GN. Thank you, Professor Omar Farooq. All yours now.
Yeah, thank you, Professor Qadri, for kind introduction, and thank you, Professor Amr El-Husseini, for invitation. I think this is very interesting case, and Dr. Al-Mashati, she presented it very well. So we are dealing, all of us, sometimes have to deal with these dilemmas, which is diagnostic dilemma and management dilemma. The urgency is like what to do when you see, there is so much disease process, or what I described like things on fire. So you don't know what's causing the fire, but you need to take care of the fire as well. So what I see is pregnancy. There is an AKI, which to the extent that we did the biopsy, and then that shows ATN plus finding of TMA, which is thrombo, the microangiopathic process. We see MAHA, microangiopathic hemolytic anemia process very clearly as well. And now patient has also neurological findings as well. So you see this constellation of finding with the background of pregnancy, with the background of heavy bleeding. Do we know what was the reason for the heavy bleeding? That was this, like, did we ever find, was there any like OB related or any like surgical issue, or this was just spontaneous? That was one question. Dr. Al-Mashati, do you remember what was the reason for heavy bleeding that started this all?
I think, Dr. Omar, that the cause of bleeding might be surgically related, because the patient lab before delivery regarding platelet coagulation profile were normal.
Okay. So you see that. So that's the dilemma in these patients. And I just had, not a couple of months ago, I was on service, and we had exactly similar patient who just delivered the baby, and next day platelets dropped, and in 2 days the platelets were like 10,000. That patient did not have significant bleeding. So these are emergencies for nephrology. We see hyperkalemia as emergency to do urgent dialysis, but this is a hematological emergency where they need sometimes our help and sometimes help from pathology to make sure that they can do plasmapheresis. So it's kind of, when you have these mixed things. So really my approach, or I'm sure like approach for most of folks in the group is, you go and you take the fire. So there is a plasmic score available, if you want to just put these things into mild, moderate, or severe. So that looks at platelet count, that look at evidence of hemolysis by LDH, more reticulocyte counts, and indirect bilirubin. And you want to make sure there is no cancer, there is no, transplant, MCV is lower, and there are a couple of more criteria. So creatinine is usually, I think in that criteria, is less than 2. So it leads to me, it looks like pregnancy triggered one of the 2 primary TMAs. So what are those primary TMAs? One is called TTP, which is thrombotic thrombocytopenic purpura, and then that does not come in package with kidney failure. You don't see kidney failure as predominant feature. What you see typically is this ADAM-TS13 activity is less than 10%, and yours is 10 to 20%. So 13% is closer to 10%. It's very low. The other primary TMA you see, which is triggered by pregnancy, and we have seen several cases, is really the complement-mediated hemolytic uremic syndrome, and that actually comes with kidney failure predominantly. So that is one diagnostic dilemma. The second thing is that you see that the ADAM-TS level is low, but then there is kidney failure. But the patient is in front of you. The patient did not read books. So you are in the room. You have to do something. So to me, you did the right thing by doing plasmapheresis, because what happens that this ADAM-TS13 that actually breaks down the von Willebrand factor from large multimers to small particles. When the activity is low, the large particles are released in the circulation, the large multimers, and they really fight with the platelets and make that microthrombi, and then there is the entire endothelium is on fire. So what you do with plasmapheresis, it does 3 things. One, it removes the potential antibody because this process is triggered by an autoantibody against that Adams TS13. That's why the activity is low. So this removes the antibody, number one. Number two, it can also remove that junk, that large von Willebrand factor combined with the platelets, which is really circulating in the circulation. It will take care of that. But the most important thing is the FFP, or fresh frozen plasma, in that it actually provides you the resource of the Adams TS back in the circulation. So you have, that activity is there, and that activity will go and start cleaving the von Willebrand factor. So the process actually stops. So once you have done, 10 treatments, then you're really, the marker which you look for is the platelet count and LDH and hapto, maybe to some extent, to determine when to stop. Once the platelet counts are above 150,000 for 2 days, it's okay to stop. Now, kidney failure, whether this occurred ATN due to this TMA process or ATN due to, the regular ATN we see in sepsis or we see in hemorrhagic shock, it will take its time to recover. What really, I think, like two more things is, like, what if this was a complement mediated TMA, which we actually need genetic testing, and that should have been sent simultaneously along with the anti-factor H antibody, because if you have genetic testing positive, then you need to urgently give this patient eculizumab. So in addition to plasmapheresis, we also do treatment with steroids. If patients have high risk, which this patient falls into due to neurological findings of seizure, then you give a gram per day for 3 days. And then the second therapy is, like, once the Adams TS13 is so low, then you know that there is an antibody, so you can start on rituximab. So once the platelet counts recover, you stop the plasmapheresis, you continue, then you taper down steroids and rely upon rituximab. There is another antibody which is very specific to von Willebrand factor. It's called caplacizumab. So if it is available, it's very effective. And you also wait for the genetic testing. I always send for the genetic testing for hemolytic uremic syndrome from complements. If there is a disorder, then you have a definitive therapy, which is eculizumab or ravulizumab. So this is how, again, takes time. So at 10 days, you should have the Adams TS13 back and see where that lies and what the platelet count. But you stop TPE based on platelet count, not based on the kidney function. And you make sure that if your patients are not responding, then you go for alternative testing. And also sometimes you have to be more aggressive with those antibodies, rituximab and the caplacizumab. So I stop here. And I request Dr. Qadri to share his feedback. We just want to make sure that we stay in time. And if there's a question, I will look in the chat as well.
Yeah, thank you, Professor Omar. I think you very nicely summarized the course and exactly how one should go about it. My only thing about this particular case is that occurring around the peripartum period, not having the classical pentad of TTP, the plasmic score, probably, I'm not sure what it was, but it's probably less than 5 in this particular case. Do you think maybe the seizures were related to eclampsia, postpartum eclampsia? Could that have been one of the things that clouded the diagnosis? I know she had proteinuria and hypertension and all those things. The other thing is that with the Adam TS coming back as 13%, would that now, since the patient is still on dialysis, push you towards using eculizumab at this point and stopping the TPE, because the kidney still hasn't recovered? I mean, this is just 1 or 2 points that, I mean, like, since we do not have the genetic testing, it's not available in this particular center. Should we then, after having done all these sessions and, of course, everybody would have started off with the Plex, and that's fine. But when the Adam TS comes back as 13%, would you err towards now using eculizumab, thinking that perhaps it was a complement-mediated, acquired, pregnancy-induced AKI?
I think great question. So there are, again, confounding. This patient certainly did not read the book or what the algorithm is, written in the books. So that's where the decision making is. So if the ADAM TS13 is like 13%, so it's low, but not less than 10%, but it's very low. If in the beginning patient got rituximab and you're not seeing any improvement in the kidney function, to me, anytime you have a pregnancy and kidney failure and the TTP, that is more like complement mediated because we didn't have the genetic testing back. If you have access to eculizumab, I will 100% try that eculizumab. Actually, in my patient 2 months ago, we started eculizumab before even, once the ADAMS TS13 was normal, I just quickly gave the patient the drug. And I saw, like, with one dose, next morning, the platelet counts were okay and kidney function was started to recover. So certainly that should be considered because those are the two critical decisions, TPE and when to use eculizumab. Earlier, the better. So I wish that if you did not have this much confounding, but you know what, when you have a patient in front of you, then you need to take a decision. If nothing goes right, take a left turn. I agree with Dr. Kadri that if its patient is not responding, I would certainly give a therapeutic trial of eculizumab at that point.
Thank you.
Thank you so much, Professor Omar and Professor Mushtaba. I just have a quick follow-up questions. So if this patient doesn't recover her kidney function and she will be maintained on dialysis and she will be seeking for a kidney transplant, what would be your recommendation? That's a question number one. And my question number two, if she wants to get pregnant again, what would be your recommendation?
Yeah. So it goes back to what is the underlying problem. So if this is complement-mediated HUS, that has a tendency to recur after transplant, and it actually can fail the transplant. You will be surprised that some people have done combined liver and kidney transplant because that takes care of the complement problem because it's actually less expensive as compared to giving them eculizumab or revolizumab for the rest of the life. And I've been in both situations for some patients which we have discussed this thing. So getting another pregnancy based on, if this time there is a trigger and if patient has underlying, tendency based on, because this condition has a risk of relapse, maybe 40 to 50% at any time beyond 2 years. So if there is another trigger, it tend to relapse.
Very good. Would you highly recommend doing complement H, complement I, membrane cofactor protein if she seeks for kidney transplantation?
Yes, so that genetic testing should be completed. And now we have genetic testing for ADAMS TS13. And there are 6 or 7 other gene mutations which are available. The other thing is antibody to complement factor H. If that antibody is positive, that makes the decision easy that this person has antibody at the time of transplant. You just give them rituximab to make sure that, you keep it low. But if this person has genetic mutation of complement, and that this can trigger, then they need either eculizumab or revolizumab around the time of transplant and in the post-transplant period, because some of the mutations, they have a very high recurrence rate.
Thank you so much. I think we need to move to the next presentation. Dr. Shuk, would you like to present, to introduce the next presenter?
Yes, thank you, Dr. Am. Thank you, Dr. Omar, Dr. Mushtaba. Our next case presentation is a case of post-transplant recurrence of glomerulonephritis that will be presented by Dr. Mohammed Al-Hadidi, a consultant of nephrology and transplantation in Mansoura Urology and Nephrology Center. Please go ahead, Dr. Mohammed.
Thank you so much, Dr. Ashrouk. Thank you so much, Professor Am. My dear colleagues, I'm very pleased to be here with you today. So today, our case for discussion is a 38-year-old male patient has been end-stage kidney disease on chronic hemodialysis since September 2017, secondary to focal segmental glomerulosclerosis, which has been diagnosed just 3 years before the initiation of dialysis. Apart from focal segmental glomerulosclerosis, the patient suffered from hypertension and was maintained on 2 antihypertensive drugs, and the surgical history was unremarkable apart from arteriovenous fistula creation. The patient received live-unrelated kidney transplant from his wife, a 35-year-old female. Regarding the immunological workup, it was okay. The HLA tissue typing was 3, out of 6 mismatch was negative, CDC cross-match. The panel reactive antibody class 1 and 2 were 0% with no preformed antibodies. So the patient underwent right renal allotransplantation on May 2021. The induction immunosuppression was thymoglobulin, and the patient was maintained on steroid, tacrolimus, and MMF, and this is the protocol for kidney transplantation in our center. The post-operative and the peri-operative course were smooth with unremarkable events. On day 5, the urine output was 7 liters. The lab parameters, the serum creatinine was fine. However, we noticed that the serum albumin started to decrease. It was 3.9 early post-operative, but 5 days later, it decreased to 3 grams per deciliter. The cholesterol, total cholesterol was 260, a little bit high, and the urine analysis showed 3+ signs proteinuria. The graph Doppler showed cortical perfusion, patent artery, and vein. So the post-operative course in our hospital, it remains for 2 weeks. The patient discharged on day 15, and on day 15, the patient's urine output was 5 liters, and the serum creatinine was 0.9. That was its nadir level. The serum albumin was 2.3 gram per deciliter, and the cholesterol was high, 320. The urine analysis showed proteinuria, and the 24-hour urinary protein was 12 grams per day. The Doppler was fine, and the group meeting decision was that the patient, besides his maintenance immunosuppression, he should start conservative management for a suspicion of early recurrence of focal segmental glomerulosclerosis represented in the presence of statins, ACE inhibitors, and furosemide just in case of edema at his lower limb bilateral, and to be monitored closely at the outpatient clinic regarding his serum creatinine, serum albumin, cholesterol, and the protein creatinine ratio, or the 24-hour urinary protein. So the routine follow-up at the outpatient clinic, 1 week later, the serum creatinine was fine, the tacrolimus trough level was accepted. However, the urine analysis showed persistent proteinuria despite the ACE inhibitors. The cholesterol was 275 despite the statin, and the proteinuria increased from 12 grams to 20 grams per day. So we proceeded for graft biopsy. Now, what we see here is a light microscopy for our graft. This is a hematoxylin and eosine stain. We have the picture of 2 glomeruli. One of them showed no abnormalities, and the other one shows shrunken ischemic tuft. You can notice also that some of the tubules were dilated, attenuated, and sloughed lining, denoting the presence of ACN. Closer aspect of our biopsy, we showed that our glomerulus showed no glomerular abnormalities, no basement membrane thickening, normal mesangium, no mesangial hypercellularity, normal bone, normal base membrane thickness. However, the interstitium show a little bit of inflammatory infiltrate. And we examined for the presence of tubular C4D, and they were negative. So this is the electron microscopic picture of our patients. We can notice that this is the capillary base membrane, and the outside is the podocytes, and we can see that there is diffuse effacement of the podocytes involving many capillaries. Diffuse effacement, it included more than 80% of the podocytes of the basement membrane of the glomeruli. Also, on closer aspect, we can notice that besides the diffuse effacement, we had also microvillus degeneration of the podocyte. And we have here a podocyte detachment and showed vacuolization, denoting the presence of podocytopathy. Also, the patient has early chronic changes represented in the multi-layers that surrounded the tubular basement membrane. For the final diagnosis, the graft biopsy showed patent capillary loop, however, diffuse food process effusion, normal sized podocyte, but some showed vacuolizations, some were detached, focal multilayering in the peritubular capillaries. There are no deposits, no mesangial expansion, no hypercellularity, in addition to the negative peritubular capillary C4D. So our final diagnosis was podocytopathy of early focal segmental glomerulosclerosis and early chronic allograft injury, represented in the presence of mild peritubular capillaries multilayering. So this represents the course of our management for this patient. On the x-axis, we can see the duration post-transplant in weeks. And on the y-axis, we can see the 24-hour urinary protein. So we started the biopsy and we started the active management when we noticed that the patient has increased urinary protein concentration from 12 grams per day to 20 grams per day, and the conservative management had no effect. So in the ninth week, we started our plasma exchange. The patient received 3 sessions of plasma exchange, and we noticed just fluctuation of the 24-hour urinary protein. It ranged from 15 grams per day to 20 grams per day. And on the 12th week, the patient's urinary protein increased to 25 grams per day. And the serum albumin was low. The patient has a pitting edema, ankle edema, which was recovered by furosemide. So our group meeting decision decided to use rituximab. Okay, so in the dose of 375 milligram per 1 meter square for his body surface area. The patient received weekly dose rituximab, 4 doses. Each one is 1 week apart. And we can notice that when we started the rituximab, the serum, the 24-hour urinary protein started to decrease, and then just a little bit fluctuation and started to decrease after the 4th week of the treatment. 4 weeks later, the patient has 24-hour protein not more than 6 grams per day. So the patient received 1 session plasma exchange. The patient received 3 times a session plasma exchange for 2 weeks and 1 dose of rituximab for 4 weeks. So this is our last laboratory results of our patient in the outpatient clinic about 1 month ago. His serum creatinine was 1.2. The 24-hour protein was 6 grams. Although it's not totally treated, however, it was managed, reducing the proteinuria from 20 and sometimes 25 grams per day to 6 grams per day, and the serum albumin was 4 grams. The patient has dry lower limb, no further need for furosemide. However, he is maintained also on statins and ACE inhibitors. So that's the end of it.
Okay, so I think I'll just take off. Professor Amr, you want to say something, and or you want me to continue?
Please go ahead and lead the discussion.
Yeah, so thank you, Dr. Mohammed. Fascinating case here. You know, if the previous case did not read a textbook, this probably did. And so, you know, you have somebody who's a young person who has a live non-related transplant received from his spouse. And earlier on, there was a history of progressing with FSGS, primary FSGS, to end-stage renal disease with a rapid course over 3 years. And that itself perhaps could have prompted a discussion of what would be expected post-transplant. And I'm sure counseling was done that these are the kind of people who may recur early, and particularly, you know, so young people, they would have more of a course, especially when the recipient is young. They have a more fulminant course when there's a rapid pre-transplant progression to end-stage renal disease, when there's very high proteinuria pre-transplant, and then here within 5 days you started having 3+ proteinuria, 3 to 5 grams, which very rapidly progressed to 15 and 20 grams. And despite all the measures they took, the proteinuria was hovering around 12 grams and albumin was very low, full-blown nephrotic syndrome. I may have even considered doing the PLEX much earlier, recognizing once the biopsy was done and you had diffuse effacement of the food processes, more than 80-85%, that probably obviously a circulating permeability factor was involved here. And I may not have waited for even 9 weeks, but that's hindsight is 20/20, like they say. So perhaps there was a reason why one waited for 9 weeks. One may have even considered doing this earlier on. And then, of course, there are certain reports like in the Tango study and others where they have looked at these kind of patients with FSGS and recurrence, where it seems like plasma exchange plus rituximab may have some beneficial effect. Unfortunately, this proteinuria is still 6 grams. However, the patient is with a combination of this rituximab and Plex, and as well as the ACE inhibitors and others. The nephrotic syndrome is no longer there. You have nephrotic range proteinuria, but the albumin. So I think that's a pretty good early outcome, but long-term prognosis I think would remain guarded. I would not let not steal the thunder of John Paul, our fellow here from Tanzania, and let him present his discussion on this case, and then we can address questions in the chat box and any other comments from our expert panel. Please, John. Thanks.
So our next literature view will be presented by Dr. John Phillip. Dr. John holds both Doctor of Medicine and Master degree of Internal Medicine in SK Hospitals, Arusha, Tanzania. Please go ahead, Dr. John.
Thank you very much for that introduction. I hope you can see my slides. And you can hear me?
Yes, go ahead, please.
Yeah, clear.
Thank you very much. So we are going to go through a few rich review about the post-transplant GN. These are my highlights. So as we know, GN is among one of the common cause of the end-stage kidney disease. It is contributed about 10 to 32% of the terms of prevalence, and incidence in the prevalence range in 17 to 53%. And it contributed to 25% of patients in dialysis as well as in transplant. Just like any other cause of end-stage kidney disease, transplant is the definitive management. But recurrence of the GN, it is affecting these measures, and we are seeing about the incidence of recurrence in 3 to 20%, and this contributes to about 50% of graft loss. And these numbers, they change based on the duration of the follow-up, the protocol of doing biopsy, as well as the type of primary GN. Recurrent GN is one of the leading cause of the graft loss, preceded by the immunological rejection, chronic, and followed by the acute rejection. So as a nephrologist, you have to understand to elaborate to our clients the risk of the recurrency, the associated factor, as well as the treatment and prognosis. This information paramount to our clients. And in this review, we see that it is recurrent GN is it occurred in about the incidence is 3 to 20%, and the most common is actually the MPGN with membranous nephropathy. The most common is membranous nephropathy, with the least common, which is MPGN. And it is documented that the shorter duration, the young age, higher pre-transplant proteinuria, living donor transplant, and acute rejection and smoking after the transplant being associated with the recurrence of GN. Looking at these 4 major primary GN, the most common FSGS tends to appear early in time, and you have more likely to lose the graft when you have MPGN is recurring. By definition, the recurrence GN, it actually appearing by biopsy, the presentation of the native histology of the native kidney histology. And you can see here, I've highlighted the different how they appear in IgA, FSGS, membranous nephropathy, and MPGN. So in this group, it's very difficult, and as Professor already highlighted, we have a number of the clinical dilemmas on how to diagnose them and actually to manage them. Specifically with the FSGS, there are several questions that people are being asked themselves, and this is being evaluated in a Tango cohort, which is a multi-center international trial, and to evaluate post-transplant GN. we look at in FSGS, the question is, what are the clinical pathological features of the native kidney or native GN that can impose or the risk of the recurrence GN, as well as the essence of genetic testing, prophylaxis, treatment, nephrectomy, in a sense that diagnosis of this is, or presentation of FSGS is proteinuria. So do you want to do nephrectomy before you do transplant? As well as what's the best treatment of it, and the effect of the graft loss. So as we can see here, so the nephrotic range proteinuria, it's one of the most associated or risky factor for the recurrence of the FSGS. And it is noted that it's not associated with the degree of food process or the serological variant, talking about the TIPS variant or collapsing variant or whatever the other ones. Genetic testing is very important, and it's been noted that a lot of children, they have these genetic variants, and it has been noted that there's a low recurrence rate in a patient with a monogenic or familial FSGS, with the exception of the nephrotic, which has the effect in the nephrin, the gene that produces nephrin of Finnish type. Basically, it is recommended to avoid pre-transplant treatment, and nephrectomy. The idea of nephrectomy, it has found not to have any benefit. So the big question is, because FSGS is presenting more often, you want to transplant after you have lost the graft, and it has been shown that the risk of rejection, it actually increased to 8% after the first transplant, and it's almost 100% when you do the second and third transplant. And this has been shown in different studies as well. In part of membranous, it is important to note that the PLA2 antibody, it's now widely used, and you can, once you detect this one, and you may not do even the biopsy, and the detection of it before or after the time of transplant is being associated with the recurrence of the membranous nephropathy. The trial of using supportive treatment like renin-angiotensin receptor blockade is being recommended. Rituximab and other anti-CD20 has been used and shows somehow beneficial in that. The IgA nephropathy, again, it's not and last, the recurrence of it, it's about 10 to 30% in most of the cause studies, and 25 to 53% in protocol studies. There been a question in IgA on how to, if we need to avoid early the steroid use or late. And this has been back and forth. But now we don't know if we don't have yet a study. Rather, we don't have yet a study in the famous Nefecon right now, the one that is being used to treatment the budesonide, which is being used now to in the treatment of IgA. But several studies, they have been pointed out that it's very beneficial, but we don't know if it can be used in recurrent IgA. Another study is in subgroup analysis of DAPA-CKD, which actually has added 270 participants of IgA, and it showed that dapagliflozin can be used in treatment of the supportive treatment in IgA. The membranous MPGN, again, it has the increase of recurrency, and it's been associated with low BMI, transplant, presence of crescents, and proportion of glomerular, which we had crescents, as well as pre-transplant proteinuria. So common things happen common. What about patients who have DM in the effect of DM in recurrent GN? So we do know that the albuminuria is presented as a clinical diagnosis, and the patient with DM, about 30%, 40% of them, they will present with DM nephropathy. But we highlighted back with a study from Mazucho, which I evaluate about 400 biopsies, and noted that there are other presentation of kidney disease, talking about GN, in patients who have diabetes. And the FSGS has been found to be more common. And there is actually the new onset of the diabetes in patients who have transplant, as highlighted with the different incidence down there. And you can see in the patients who have the risk factor rather, it has been associated with age, obesity, race in different race, infection like hepatitis C, which pose actually a very complicated in terms of treatment, because the treatment of hepatitis C, it's interferon, which again it is associated with recurrence and affecting the kidney, and the graft loss. So this again, these are some of the dilemmas which are posed in terms of the treatment, as well as the immunosuppressive drugs, which again they have diabetogenic effect in our patient. So again, the histology, despite the fact that the diagnosis is the presentation of the biopsy of the native, but the histology actually differ a bit in terms of it has vascular and the tubular interstitial changes, and the diabetes or the new onset of diabetes in kidney transplant actually increased by 2 to 3-fold in development of the cardiovascular, and actually increase the loss of blood failure and death censored graft. So what does it mean to recurrent GN in patients who, to our graft in patients who have recurrent GN? So as you can see, these graphs, they portray the effect of the recurrent GN. You can see in dotted lines, all these are represent the patient who have recurrent, and in straight lines present to patients who are, and they don't have recurrent GN. You can see clearly patients who have recurrent GN, they are more at risk of losing, as well as this one represent the same thing. So what are the solution of these challenges now? So different GN, they have different approach, as you can see in this table. So the part of the IgA, again, from what are the challenge, and then you can see the part of the diagnosis. You have only supportive, the ACIs, ARB, steroid, as I mentioned here. So there is no yet to be included the dapagliflozin, as well as in part of the steroid, the budesonide, which is now the talk. In part of the membranous, the use of the ACIs, rituximab, in part of the focal sclerosis, which we're going to look at it much better in a few slides. So focusing on the FSGS as our case presentation, that is our case presentation earlier, we are going to review the cohort of the TANGO, which actually look at, as I said, different, it was an international study. So this is just show the timeline of how many studies that have been done and up to now where we are. And basing on the TANGO study, TANGO cohort, it has been shown that the recurrency is actually about 30%, 1/3 of the patient have recurrence of FSGS, and the mean time is 1 to 2 months. And these ones, they will have graft loss, which is basically on the geographical region. And really the factor that have been associated with is a prior transplant, as I said earlier, the low BMI and nephrectomy in these patients. The other factors that they looked at in living donor versus deceased induction therapy, they were not associated with. The graft survival in this group, they were actually 5-fold higher and it was associated with failure to achieve remission. Just to wind up, the part of the management that has been put forward is again FSGS, SGLT2 as I highlighted, and this sparsentan, which is endothelin and renin-angiotensin receptor blockade, has been shown to have more benefit. There's much question in terms of the rituximab in the plasmapheresis. Other studies, this is a systematic review that showed that there's no benefit, but in the TANGO studies, it is shown that it's promising, and as we were seeing in our case, it was promising. So maybe this one can be used right now. So these are the part of the treatment that we can use to our patient. Having said that, I would like to say thank you.
Thank you, Dr. John Philip, for a very comprehensive overview. And I think, the take home from this is, in a sense, that yes, if you are doing surveillance post-transplant, I think proteinuria is something that needs to be looked at early, particularly for all the primary GNs that we transplant. I think some of the highest forms of recurrence, very important pre-transplant counseling is required. Particularly when you're dealing with live donors. Although live donors or cadaveric donors doesn't make a difference to the outcome, but it certainly would make a difference to what a donor feels after donating to somebody if somebody develops rapid recurrence, like in our case here with the FSGS. I think we need to be cautious with things like dense deposit disease, extremely high recurrence, up to 9,500%. C3 glomerulopathy, again, about 60 to 80%. And then, of course, FSGS is a very common cause of graft loss, a six-fold higher loss of graft. You've also alluded to IgA nephropathy, very common. Seldom you lose graft with that. With good diabetic control, you might delay the onset of recurrent diabetic nephropathy. I think you highlighted that. Membranous, you want to make sure that the PLA2R titers are low before you transplant. I think that is important. There are others like the ANCA-related, vasculitides, the GPA, and others, where it seems like the disease activity should be quiescent, although the ANCA titers per se do not predict recurrence. So it's a whole science out there. You have very nicely, in a short time, covered all that. And I'd like to go straight to the chat and see if over the next few minutes we can address some of these questions. And I'd like our guest speaker to try and handle the first ones and take them as they come. So I guess there was one question. I think somebody was talking about DIC with cortical necrosis in this case. The patient, if the patient is, anuric or oliguric less than 100 ml or so, I think that's certainly a thing to consider in that particular case. But the issue of somebody felt that doing plasma exchange for the first case was overdoing it. Now, that is something that I'd like Dr. Omar to comment on. So was plasma exchange overdoing it when we did not have ADAM TS levels and complements were not available in somebody with as serious a consideration as a presentation as we had in the first case? Dr. Omar?
Yeah, thank you, Dr. Khatri. I think going back to it's really the sense of urgency and ability to identify those emergencies. And I agree, there are some times that we may be wrong, we may be overdoing things, but think about the benefit. The mortality for these conditions, either left untreated or delayed treatment. Untreated mortality is 95%. Delayed treatment, you're talking about the organ loss. So I probably shared with you, we have somebody in the family who did not get the eculizumab timely, so they lost their kidney just because. And hindsight is 20/20. Like when you look back and then you ask yourself, like, oh, had I not done this treatment timely? Second, I think one point I definitely related, you highlighted, when FSGS comes back, it comes back with vengeance. The proteinuria is like 20-30 grams, it's massive. And it can also hurt the kidney pretty bad. So even you mentioned, TPE earlier on for that case would have led to maybe shorter duration of therapy and quick remission. And we have seen both ways. Maybe I think I want to also emphasize the point you mentioned. So for recurrent FSGS, we diagnose these conditions when we see these patients in the pre-transplant condition. So you predict the recurrence at that stage and you do the counseling and built in the protocol how often you want to do either PLA2R or the proteinuria assessment, because having that level of vigilance is really needed and required of all of us nephrologists to make sure that we give this benefit back to the patient. So I'm not disagreeing with the question, but if I'm treating that patient, I would go on the side of treating rather than wait and see, and then which may lead to irreversible damage.
Thank you. And I think, some of the other questions were dealing with, again, the first case were regarding whether it could have been simply, because of the massive, because of the DIC and the massive bleed and transfusion, could it just be ATN and cortical necrosis and all that? And of course, we had things like the low platelets and the neurological manifestations and the LDH and the MAHA and everything. So obviously we were dealing with the TMA, all right, and whether the TMA also in itself led to acute tubular necrosis, and I think that's something that even the biopsy showed. There are some other questions regarding albumin level before transplant. So in that particular case, Dr. Adedi, I think you yourself are saying that there was no family history of renal disease and albumin level on dialysis was above 3.5. And I would have assumed that even the proteinuria had come down when this patient was on dialysis at that particular time over the 2 years, 3 years, and we don't even know what the residual renal function was, probably with the hemodialysis for 2-3 years. That after which the patient was transplanted, maybe the volume was just not there to have that much proteinuria in any case. The other question somebody has is, will rituximab replace plasma exchange in our upcoming future for FSGS recurrence? And I'm not sure what the answer to that would be, because the circulating or permeability factor obviously has to be removed regardless. Rituximab does not have a great track record in primary FSGS, and it's just that in this particular TANGO cohort, I think combining rituximab with plasma exchange seemed to be a little better than plasma exchange alone. Do you have any comment on that, Omar?
Yeah, I think jury's out. I agree with you. What we really need is the proper identification of that factor, which we call it circulating factor. I know there have been some advancement, and then we step back and advancement and step back. You remember SUPAR story. The SUPAR was coined as the permeability factor. So we really need the permeability factor directed therapy. So a monoclonal antibody that can really capture that that factor to treat these conditions, because rituximab in this case is shotgun approach. So is the TPE. So you don't know what you're treating, but you know when you treat it works.
Yeah. And I think some of those subsequent questions are also related to rituximab and whether CD20, 20 counts, CD19 counts need to be done and all that. But like you said, it's a shotgun approach. I think they did, like what they could at that time, and they have the results of 6-gram proteinuria, at least nephrotic range, but not nephrotic syndrome. And finally, somebody is talking about sparsentan and other things. And I think these supportive therapies probably can all be used out there, in the absence of any contraindication. I think one could use all these supportive therapies. So I'm going to stop right here. I'm going to thank our panelists, guest panelists, Professor Omar Farooq, and our host, Professor Amr El-Husseini, always for bringing us all together, Dr. Sharouk for coordinating this webinar, Dr. Asma and Dr. Muhammad and Dr. John Phillip for doing wonderful literature reviews and summarizing the thing, and of course to our audience who have participated actively by posing challenging questions, and I hope we've answered some of them. And it's all part of the learning process. So thank you everyone for being part of the World Kidney Academy fellowship programs. The GN fellowship programs is enriched because of your participation and your presence. And I'm sure most of you are experts, more than some of the so-called experts on the other side, on the faculty, because you have gone to an in-depth review of all that is current and answered MCQs, which have been pretty challenging throughout this fellowship. So thank you for being part of this, and good luck to everyone, and take care, and good night, good evening, good morning, wherever you are. Thank you, everyone. Take care. Bye-bye.